The International Association for the Study of Lung Cancer entered the 1980s with a fabulous start centered on the Second World Conference on Lung Cancer. It was held in June in Copenhagen, Denmark, and Dr. Heine Hansen was the conference president. The conference attracted more than 1,000 registrants from more than 38 countries. It would set the stage for the IASLC to unite internationally. It would be a decade of much growth, both for the organization and the science of lung cancer. This was also the time researchers looked at giving vitamin A to patients with exposure to cigarette smoke or asbestos. While the impact of the supplement on lung tissue wasn't studied, it's one of the early examples of science-driven translational research. Shortly thereafter, scientists in Japan were studying the effects of secondhand smoke on women.
Looking at the tobacco use, not only is it from smoking, but also from secondhand smoke. So that was one of the first decades, was looking at the article from Japan that was looking at the risk of a woman, for the most part it was the women living with spouses who smoked, and their risk for lung cancer.
The study demonstrated that the wives of Japanese men were at risk for developing lung cancer even if they never smoked, because their husbands smoked 20+ cigarettes per day. Studies later in the decade would confirm this, showing that the risk of non-smokers getting lung cancer was tied to their exposure levels of secondhand smoke. The Third World Conference on Lung Cancer was held in Tokyo, Japan in May of 1982. Congress President Dr. Ishikawa hosted more than 1,500 attendees from more than 30 countries.
The most important thing is at that time that Japan doing so-called clinical trial by ourselves, okay, not global one. But IASLC offered us global idea how to conduct global trial, the importance of global trial. That's very, very important for me. When I joined a small society, at this moment, the number of members is still not so big, but at this time very small. And but a very famous doctor joined, and we became very good friends.
In 1983, a study was published showing the benefits of a technique called TBNA, or transbronchial needle aspiration.
And that allowed the bronchoscopist to take samples out of mediastinal nodes and thereby staging the patient, which until then was only possible by cervical mediastinoscopy by a surgeon under general anesthesia. So in terms of mediastinal lymph node staging, it was a very important step forward. The other important step in the assessment of the patient was the functional assessment, because in the 80s the data and what we knew about pulmonary function test and exercise testing and how this determines the fitness of a patient for surgical resection was really very much expanded in the 80s.
In the area of immunology, scientists were also making progress.
So in the 80s, our understanding of the regulators of the immune system had evolved somewhat, and we had started to identify some of the cytokines and the components of bacteria that incited an inflammatory response. And so there were trials of injections of cytokines and some of these extracts of infectious agents in the 80s in order to refine on the observations of the 70s and earlier about infection.
In the mid-80s, there were two advances in the area of pathology. The IASLC Pathology Committee proposed a revision of the World Health Organization classification of small cell carcinoma. The new proposal would eventually be adopted in the 1997 and 2004 WHO classifications. Also in pathology,
in the 80s, investigators were starting to report the increasing prevalence of lung adenocarcinoma and the decreasing prevalence of squamous cell carcinoma. And these are clearly related to the type of cigarettes that people are smoking.
In the area of treatment, researchers were taking a multidisciplinary approach, combining the areas of surgery, immunotherapy, chemotherapy, and radiotherapy.
In 1980s, people were struggling to improve the survival by adding something to the surgery. So, in this scenario, the North American Lung Cancer Study Group launched many important studies. The adjuvant chemotherapy. This is the first series of trial. The surgeon tried to get something to improve their survival, although some of them failed to demonstrate the prognostic significance. But I think that year was the first time that in a collaborative way we studied the adjuvant trials.
The mid-'80s was also an active time for the IASLC. The Fourth World Conference on Lung Cancer was held in Toronto, Canada. The conference president was Dr. Ronald Feld.
We were very happy to be able to host this convention. It took us a long time to plan for it and to put it together in such a way that it met the requirements of this very important type of meeting.
The conference, held in August of 1985, had more than 1,000 registrants from 33 countries.
The IASLC has both grown and changed over the years. It's grown in the size of its meetings, the number of members, and I think it's the kind of most important organization in the world for this malignancy.
The same year of the World Conference, the IASLC expanded the newsletter that Dr. Lawrence Broder first disseminated in 1975.
It started as a newsletter for IASLC, and Dr. Hansen, he wanted my help and assistance with this newsletter. And so we developed that together, and that turned into a journal, and that was a journal Lung Cancer. So yeah, that was the lung cancer journal at that time and for many, many years.
This Congress.
While Dr. Hansen was developing the journal, another IASLC pioneer was proposing a new staging system for lung cancer.
Many years ago, the UICC decided that they needed to have an international tumor, lymph node, and metastasis, so-called TNM staging classification for all cancers. In lung cancer, obviously it needed to be based scientifically on cases. In the beginning, Dr. Clifton Mountain, who was one of the original officers of the IASLC, took a large number of cases that had surgical resections at the MD Anderson Cancer Center in Houston, and he collected the outcome from these patients. And the original TNM classifications were based on the 5,000 to 10,000 cases that he had collected.
In the areas of screening and radiology, scientists were testing to see how chest X-rays and sputum cytology could detect and screen patients. While X-rays detected more early-stage lung cancers than non-screened patients, the 5-year survival for screened patients was still less than 20%. Sputum cytology was helpful, but mostly for squamous cell carcinoma.
At that time, the screening project with chest X-ray and sputum cytology had was just sort of completing, and it wasn't clear that chest X-ray screening was going to decrease lung cancer mortality. Subsequent analysis of that study showed that it didn't, so chest X-ray screening really never became standard.
In radiation oncology, researchers would demonstrate that 60 Gray was the most effective dose in non-small cell lung cancer. In addition, scientists were showing longer survival rates in small cell lung cancer patients with the use of radiotherapy and chemotherapy.
One of the major changes in the 80s in lung cancer with the radiation therapy is combining the chemotherapy with the radiation. So for the very beginning of combined modal therapy was constantly developed in the non-small cell as well as small cell lung cancer.
Also in the 80s, the techniques for culturing the various components of the immune system were being developed. T-cell cultures could be performed, and we were starting to learn about antigen-specific immunity, and our knowledge base was growing, but without real application to lung cancer therapeutics at that point.
In the era of chemotherapy, scientists demonstrated the survival benefit of the treatment.
But even in non-small cell lung cancer, most people don't think about the fact that these subsets that are molecularly targeted, these oncogene-driven tumors, are still a very small percentage of our patients. For instance, with advanced non-small cell lung cancer, by far, many more people receive chemotherapy. And we know now, number one, that chemotherapy is better tolerated. We have better supportive care to give chemotherapy. But it improves survival, and it improves quality of life, and it reduces pain or other symptoms that patients are having. So chemotherapy remains a very useful tool.
In supportive care, scientists developed a new quality of life tool. Conclusive evidence was found for the positive effect of good performance status and overall prognosis, a tenet that still holds true today. There were long-term survivors of lung cancer and research centering around surviving the disease. In 1988, the 5th World Conference on Lung Cancer was held in Interlaken, Switzerland. Dr. Rudolf Joss was the conference president. More than 1,000 people attended the conference. The 80s was known for slow but steady growth in the IASLC and in lung cancer progress. Shy of 1,000 members, the organization was growing and seeing the benefits of uniting internationally.